We have a special treat for you this episode. On this interview with a very different type of healthcare expert, staying on the theme of healthcare policy, that Matt and our producer Sarada will tell you a little bit more about in just a second. Just want to make one important note that the date of this recording is October 11th, 2017, but the content is still extremely pertinent today. We are definitely still in the grips of an opioid crisis, and we go into themes from somebody who knows a lot more about that.
And part of what we really want to introduce into this new season is perspectives on the ground. So to tell us a bit more about that, we'd love to welcome in our producer, Sarada, to explain a bit more about that concept.
Hey guys. So the phrase street-level bureaucrat was originally introduced by Michael Lipsky, and in his exact words, he defines them as people who deliver the policy that has been constructed elsewhere. So essentially, our street-level bureaucrats carry out or enforce policies that they didn't design. And the interaction between the policymakers' intentions and the implementers' actions can highlight the disconnect between what we think will happen and what actually happens when a policy is passed. So acknowledging this discrepancy, we hope to interview our street-level bureaucrats to kind of better understand how policies actually affect the public.
Exactly. So to that end, we'd love to jump into our interview with our first street-level bureaucrat, Dr. Priest, to talk about what healthcare is like on the ground in Michigan. In your experience as a practitioner on the ground, how has your practice changed with the passage of the Affordable Care Act?
Well, I'm in family practice, and we see a variety of patients across the spectrum. I see a lot of young adults and middle age as well as older patients. We take Medicaid in our practice, which is unique in this area. A lot of the doctors don't do that. So that piece of it, one element of it, we saw an increase in access for many of our patients that didn't have insurance. The adults that got access to health care. So that's one large piece of it right there. I would say is probably the major thing that we're seeing in our practice as far as what the ACA has done for our patients.
Right. So more Medicaid patients, right? Like more low-income folks?
Yeah, the people that didn't have insurance, so obviously didn't have access to care. Many of those patients either didn't get care, if they did, it was through urgent care or ER. Mm-hmm. So it created a burden on our health system. And this, in northern Michigan, there's limited options.
Yeah.
So it expanded access for primary care, which, I'm an advocate for. It's real important to have that access for our patients. Yeah. So that piece of it was very obvious for our clinics, for the patients that didn't have insurance. And it's just one element.
Sure, and sort of from the practitioner standpoint, sort of has your experience sort of day to day changed, or like on a day to day basis, do you think about the Affordable Care Act, or is it something that sort of looms kind of in the background as a policy, but doesn't exactly inform kind of your day to day work?
Yeah, that's a good question. I would say, most doctors like me that, do day-to-day work and go and see patients all day long. We're just about good patient care. And so get in the trench and work hard. And so, I would say most of my colleagues that I know, probably don't think a lot about that or talk a lot about it. We just, get the work done. I mean, that's kind of what we're doing.
Completely.
Right.
So, no, I wouldn't say I think much about it, no.
Mm-hmm. Right. Yeah, you're actually in the trenches. Yeah. That makes sense.
Yeah.
Yeah, so looking more broadly, do you have thoughts or concerns about what? Well, it'd be interesting to talk about benefits and drawbacks of the Affordable Care Act. So maybe let's start there. Like how the way you understand it, like how has practice changed, and what are the flaws in it as you see it? Yeah.
Well, good question. I would say probably, in terms of what's positive about it, just to start there, one of the elements was that we could see patients for preventative care, and that not just Medicaid, but also other patients that, of course, have health care now that, that are in the exchanges. Those patients, we get them in. So a lot of the patients, especially younger adults and younger patients that typically do their preventative care, we're seeing clearly an uptick in patients that come in for their primary care and preventative care, and theoretically that should keep them out of urgent care and ER.
Right.
Where I think that's that's true. I would say that's arguably true.
Right. Yeah. And is that something that you have any like, I don't know. Yeah, I'd be because I understand that argument that more preventative care leads to less urgent care and ER visits. Or I mean, that's something I'd buy. Like, is that something that you've like seen numbers or facts, any statistics around? Sorry, I know you're not like a policy guy, but figured I'd ask.
No, I appreciate that. Yeah, I don't see exact numbers. We get feedback from the hospital, the local hospitals, Munson Healthcare here.
Yeah.
And also, because I'm in a larger group, there's 12 clinics, and we have 9 partners that own the practice, and we have 30 providers, and so we get feedback. One of the trends that we haven't seen, which we'd like to, is our statistics for our patient base do frequent ER and urgent care far more than they should. Mm-hmm. We think that's more just creature of habit. Some patients just aren't well educated on the need to call us first, come see us. We're available at most of our clinics to see people.
Right.
But that's just a patient education issue that we need to work harder to make that happen.
Sure.
So even though that's there, it's not utilized as much as it should be.
Right.
And if you were to like pinpoint one, like the biggest limitation that you face with providing the best care possible for your patients, like what would that be?
Well, that's a loaded question.
Yeah.
It's certainly, so there are still patients that don't have adequate health care coverage. Even despite this, I have patients that are cash patients. So there's one element there where patients can't afford to get access to care as part of it. The other issue is that with so many different insurance plans, not just Medicaid and Medicare, but the number of different policies out there, probably one of our biggest hassles is getting patient access to specialty care and extra care that they need outside of what I do, because there's so many different plans and there's different policies of how we do different things as far as getting access to specialty services. We have a lot of specialists in this community that don't accept some of our plans, especially Medicaid. We also have problems with prescription coverage. The plans are all different, and so we're challenged by when I prescribe medication that you'd think would be covered is not, so we deal with trying to figure out what's on their prescription formulary, for example, and getting the adequate care they need through their prescriptions. I would say that's one of our larger issues here in primary care.
That makes sense, yeah. And how about, so when it comes to drawbacks of like so I appreciate your discussion about, how it's difficult even with the Affordable Care Act for patients to access specialty care. Do you, I don't know, like thinking about alternative healthcare options and policies, like do you think that would we encounter the same issues under, say, a single payer system? Yeah.
That's a great question as well. I tend to be, as a primary care physician, I'm here to take care of people, and for me to do the best care I can for patients, I would, the economics again of this is challenging, but I would be in favor of Medicare for everyone. That discussed back in the prior campaigns, they talked about that, and I think that in terms of having a level playing field for everybody, have a standard formulary for everybody, everybody be on board. Then you'd have all the specialty, the hospitals, everybody be in the same system, and it'd be a lot easier to streamline their care.
Right, and that single payer system would,
not from an economic standpoint, but just from patient care standpoint, talking about quality care for patients would make a lot more sense to have a very standard Medicare for everybody type of plan.
Yeah. And so that single payer type of system would make it easier to get access to that specialty type of care, right?
What would happen with that is everyone would have to be on board, because that's what the payer would be.
Right.
See, right now in our community, we're isolated up in northern Michigan, and I would say 2/3 of our specialists on our that are available here in this community don't participate with Medicaid. It's just a good example. Some of them don't with Medicare, most do, but Medicaid, a large number don't have access to specialty care. So we're challenged every day with that, trying to find the care for some of these patients.
And so what would a patient do, right? Like if they need to see like an ear, nose, and throat specialist and they're on Medicaid, and the doctors in northern Michigan don't cover it, like what happens there?
That's an actual example where we have 3 very good ENT doctors in this town, and they They do take children with Medicaid, in fairness, but they don't take adults with Medicaid. And so patients that are out of the scope of my skill, if I need them to see someone, I either have to have them talk to their insurance plan, because there's multiple Medicaid plans, because there's different lists of doctors they can see in the different plans. I ask them sometimes to call and find out who's the closest doctor for them. It might be down in Saginaw, it might be Grand Rapids, it might be in Petoskey, and there's different doctors, and I don't know who they are, so I ask the patients to do that. Sometimes my staff will know, I try to reach out to the resources we have to try to help them. So it creates extra work for me, of course, trying to make that happen. And sometimes they just don't do it. They don't have access. As again, you're dealing with oftentimes patients that don't have a car or vehicle because they're low income. And for them to be able to drive somewhere to have access in another community is a challenge. So I would say a large percentage of those patients end up not getting that referral that they need.
Great. Yeah, that's great context. I have an unrelated question, but if you have something, okay.
Go for it.
So one of it's kind of a more out there theory of, something that I think is based in economics. Like, it feels like there's on some level like a shortage of doctors. Like, it feels like, if there was a more robust pipeline, right, into medical school, and that was more affordable and accessible to like a wider chunk of the American population, it seems like, we would have more access to specialists, and potentially healthcare costs could go down. Do you have any thoughts about like the pipeline of getting into the healthcare system? Like, if something like that would work, like, would you be in favor of incentives that encourage more people to become doctors? I don't know. This is an idea I haven't really bounced off anyone. It's kind of out there, but.
Well, I think that, there's just concepts for me that it kind of fits into what you're talking about, is that I think that, if we have the privilege to practice medicine in Michigan or in the United States, there should be some requirement for us to see some percentage of patients in our practice that are Medicaid or indigent. I think that would be, something I would support that. And I think, we could do more to encourage doctors, and actually, if they commit to working in communities that are in need and will take Medicaid, to start from scratch, bring those people in through undergrad and medical school, and actually do that. I don't know the data. I think it depends on where you're talking as far as access and number of providers. The real problem is we still live in this for-profit driven system that a lot of doctors see as a negative income factor if they accept Medicaid. So that's a barrier. It's more about the income than about the patient type that causes that barrier. So when you live somewhere far north like I do, there's just a limited opportunity for patients to have access to some of the doctors. And even in primary care, our clinics, we have, as I said, 12 clinics that cover like 5 or 6 counties, and we saw, I think, 150,000 visits last year in our clinics. So we're a pretty large factor up here, but we're the only private enterprise up here that sees Medicaid openly. We're open to all Medicaid plans, whereas the other clinic in town that's here is actually the residency training program. So all other primary docs that I know of in town can selectively see Medicaid, but aren't open to Medicaid. So that's, and we're not trying to stroke our clinics, but that's we do that because we think it's the right thing to do, and we have an economic model that works. So it can be done, and we do it, and all do quite well. So it's not that it can't be done.
See, that's so interesting to me that I didn't realize that was a decision point for clinics to either accept or not accept patients on Medicaid. It's pretty fascinating. I mean, do you know any of the internal conversations in your own clinic when faced with that decision? Like, what went into that, and what considerations did you guys have?
Oh, yeah, with our clinic, it's evolved. I've been a partner of this group for 5 years, and our clinics have evolved. They started with 2 doctors, and it kind of grew. I was, I think, the 5th, 6th doctor in this group of 9 that owned the practice, and because it was rural clinics, it started in rural areas, and so they had rural status, and so they got incentive dollars to do that. It helps you with Medicaid, it hurts you with Medicare. It's kind of a complicated mathematics there. I won't go into great detail there, but it's not advantageous to do that if you see a lot of Medicare. Yeah. So it started there, and then we evolved to we're in some larger communities like in Traverse City where we wouldn't qualify anyway. And the way some of the Medicaid plans are set up now, there's incentives built into that. And if you have the right structure in your clinics, you can capture incentive dollars, but you have to have the resources. You have to have the staff, you have to have the knowledge, you have to have the computer system, the electronic medical records. You have to have some savvy business people involved with that to make that work. And that's why a lot of small clinics with 2 or 3 doctors or solo doctors just can't do it. There's no way they have the resources to make that work.
Yeah,
that's just one element of how you can make this work, is you have to have the right resources.
Wow.
Yeah, I'd love to better understand that, because something that came up in our interview with Marianne earlier today was we were talking about bloated administrative costs on like the hospital level and how that
Sure.
makes prices a lot higher. And it sounds like, so what I heard you saying was in order to like qualify for some of those incentives, you need like a certain level of like administrative infrastructure. Is that?
Yeah, you just have to. So when I was in practice, because I've done this all. I've been employed, I've been self-employed on my own in solo practice, and I've been in a group practice that's now, I'm part of a solo practice. We own the practice, and so we self-manage, and that's the model that works the best for me. You have to have the right resources. It's economy of scale. If you're big enough, you can afford to shift some resources to do this, where we have several dedicated people that manage the pieces of the equation with these plans that help us put in place the quality measurement tools that we need, so we can measure what we're doing in terms of diabetic care, high blood pressure. You pick the topic, and there's certain things that we measure for quality, and if we meet certain measurements, we get paid incentive dollars is what happens. And so you have to have the right pieces in place to know what's going on. And plus, you also have to be resourcing outside of this in terms of what groups to be a part of. It's complicated. You have these PHOs, these physician hospital organizations that all have different models. And so we, as a group, because there's other hospitals in the region, that we worked with several other facilities. And then there's other groups that are separate from the hospital. So it's complicated with that. But you have to have people savvy enough to know, to be looking forward to say, okay, what's out there now? Like Medicare has this new plan in place that we're just building now, and you have to have someone dedicated to do that, to put those pieces in place so you can get the resources and the money.
Right.
Otherwise, you don't get paid as well, and that's why a lot of doctors don't take Medicaid. They don't fully understand how to do this.
And so these incentive dollars are tied to measurable levels of improvement?
Yeah, improvement or just quality measurements. A good example would be diabetics. There's a blood test called the hemoglobin A1C. I don't know if you're familiar with that. It's a measurement of their average blood sugars. And they set benchmarks. If you hit a certain benchmark for a certain percentage of those patients, then they pay you so many dollars per patient per year. So, if you don't meet that measurement, or you aren't able to measure it, then, of course, you're not going to get compensated for that. So you have to have the right resources in place to be able to make that work. So it's just a matter of having the right people on board, the right management staff. And again, you made a comment earlier about being staff heavy or having too much administration. And there are a lot of models that do that. They pay too many administrative people that aren't doing the right things. We're not top heavy at all. We have just the right amount of staff to make that work for us.
Right.
See, and I think this is such important context, given so as Sean mentioned, we had this conversation from like a very high policy level of, it makes sense why states would expand Medicaid and sign on to it due to the incentives. But it's been fascinating, at least for me, to hear that like the picture becomes so much more complicated when you get like nearer and nearer to the actual implementation.
Well, yeah, when you're talking about doctor-patient interaction and relationships, it's very different at this level versus the kind of things you're talking about. From rolling out the ACA and how it impacts states and all. So there's all these layers to it, right?
Completely. And
I'm at the very end of it.
Completely.
When patients come and see me, right?
Right. Exactly.
Exactly right.
And sort of beyond access too. So we talked about the ability of more people to gain insurance and then to see you. Have you spoken with patients directly of like just how satisfied they are with their health care, or any impressions of not only being insured but just the quality of care that they're receiving?
Some people, I think it's not even on the radar screen. It's just not. So it depends on the patient. I have a lot of really neat patients that didn't have care that have it now, and many are very, thankful and express that, and are happy to be able to be seen, be able to come into the office and get the care that they need. On the other hand, there are some patients that are in that mix that just, it's entitlement, and they don't really appreciate what I think they don't. They take advantage of getting almost free medication, sometimes seeking medications that they shouldn't be prescribed, for example. They see, too much of that, unfortunately. So there needs to be some accountability in the patient's part, too. I mean, that's part of it. And the other angle on that is I've got some patients that are employed that have had insurance, before the ACA came into place, that are self-employed, and they're actually, many have complained, some have complained, actually many, but a few have complained that their costs were higher. That's that carve out for some of these people that lost their plans, or at least didn't have, their costs went up, I guess I would say that. I've had a few patients, angry about that.
Yeah.
I'd love to ask you about, so you were talking about how some patients seek out medications that, they shouldn't necessarily. And everything around like prescription drugs and pharmaceuticals is really fascinating to me. I'd love to hear about, so, independent of the Affordable Care Act, like, are there incentives to give certain drugs over others? Like, is your compensation tied to what particular drugs you prescribe to your patients? Or is compensation of doctors in general, the royal doctor?
Yeah, definitely not. I mean, that would be, fraudulent to have, any connection with prescribing medication, for favor or getting paid extra money. I try to practice ethical medicine, and I, try to prescribe what's appropriate for patient care. Obviously, you have to keep in mind what's on their formulary. There's a small subset of people that are, for example, drug seeking, and that they have little to no copay for their medication. Obviously, there's an incentive to some of it's diverted. There's some element of that. We try very hard to do what we can to contain that, control that as best we can, but there's always some element of that. But there's no incentive for me as far as dollar incentive to prescribe certain medications. There used to be when I first was in early years in practice, when Blue Care Network and Priority Health were new. Their managed care plans. There was formulary incentives to push us to prescribe. We had a certain percentage of generics. You hit certain benchmarks, they would pay us more money, not for a particular drug, but just for percentages. Does that answer some of your question there?
Yeah, and so in that previous system, there was an incentive not to give generic drugs, right? To give like the brands over the generics, or
no. Actually, if we reached a certain, this again is managed care, and their goal is to keep their costs down, right? So they'd give us incentive to. They say if you hit an 80% benchmark for generic to 20% for non-generic, you hit a certain benchmark. In other words, more generics, which are cheaper, they would incentivize. They'd give us some dollar amount. So it wasn't any particular drug; it was just percentages. I haven't seen that for a long time. They don't do that anymore, partly because there's some ethics issues with that. We should prescribe what's appropriate for patients rather than what's generic or not.
So, I mean, yeah, and my understanding is very limited here, but when there is like a generic version of a drug and like the design or brand of it, like what is, the way I understand it is that the generic is typically, if not always, much cheaper. Like what is the incentive to prescribe the designer drug or the brand name?
Generally speaking, once a generic drug comes out, most of the time it's bioequivalent, meaning it's they measure these things in terms of quality of the drug as well as the percentage of the drug that's actually in it. If I prescribe 100 milligrams of a drug, it should be there's certain margins of error, and if the generic company can produce that drug and be tested and do that, then they can be allowed to sell the drug. And so those drugs are typically either a little bit cheaper or sometimes a lot cheaper. It just depends on the drug. And when they first come out with generics, obviously, usually one company is allowed to produce a generic for a short period of time, and so the cost is just a little bit less. And eventually, as more companies make those drugs, then the prices come down. What's interesting, just on that note, is that in the last year, maybe 2 years at the most, the price of drugs, any drug, especially generics, has gone up dramatically, well above what you'd expect for cost of anything. And that's something I don't understand why. We're not sure. I'm sure that there's some reasons that I don't know as far as economics. We're seeing a huge increase of drug costs, and so the formularies are much more strict for that reason. even for generic drugs that I prescribe. I've been in practice 28 years, and some of these medications have been available as generics for that entire length of time. And despite that, some of them are not on formularies now because their costs have gone up so much. I don't know. I'm not sure the reasons entirely, but I'm sure it's economic. People are making money out there.
Right.
That's my suspicion. Is it's a big profit shift out there, going to pharmaceutical dollars. Yeah.
Right. So this is sort of outside of the ACA, and forgive the pretty broad question, but seems like, in recent years there's this huge public health epidemic with the opioid addiction and opioid crisis, and I'm sure particularly in rural areas. Can you just speak to your experience as a healthcare practitioner and what you have seen on the ground, and also just any possible solutions that have come to mind, or ways that that the crisis can be fought?
Yeah. Well, I'm right in the thick of it because I'm in primary care, and we see a lot of patients with chronic pain, and some of those patients, you end up with that being one of the only options you have to help them is to prescribe a controlled drug. Opiates, obviously, we're talking about those drugs. And for years, there have been problems with doctors like myself not having the proper tools in place to help us manage that. And in recent years in our clinics, we've got a very strict policies in place that we follow. They're what we call guidelines that help us restrict some of that. That's not perfect. Occasionally, I'm sure some of my patients get medications that they shouldn't, and there's some diversion going on out there, even with medications that I prescribe. But we have some pretty strict policies about seeing those patients frequently, making sure it's justified, making sure we do drug screens, making sure we have signed controlled substance contracts. Michigan has a website you can go and pull a patient. Let's say you're a patient and we're not certain your history. We can pull that up. It's called MAPS. And we can actually look and see who's prescribed medications for you. So there's some tools in place that help us. There's a big blowback. A lot of the younger doctors, especially, I'm working with a resident, or actually a new doctor now that's in our clinic, just out of his residency, and he's very, very gun shy to prescribe opiates at all.
Yeah.
So what happens is some of the patients really are legitimate patients that need treatment. That's the only option you have, are suffering for lack of access. But on the same hand, there was a trend back to 10 or 15, 20 years ago, and I would say that it was the sky's the limit.
Yeah.
Keep prescribing. There's no dose that's too high if they need more medication. And that was largely, we know now, driven by two of the pharmaceutical companies out there that were marketing aggressively opiate medication.
Wow.
So interesting. Yeah. So I've really dialed back what I do, and I have a fair number of patients I treat, and some of them are with pain management, and some of that includes opiates as part of their care, and some of them are very good patients. They've got families, they have children, they go to work every day. They're people that are contribute to society that need it, so that they're not all sitting on the couch at home and just popping pills.
Right.
It's a challenge. And I'm on the hot seat right now as a primary care physician with that topic because we're the guys prescribing. And so now you see in the news everywhere, the blowback about that. And they talk about, these physicians that are over-prescribing. And it's a challenge because that puts me on the bubble, of course, being very, very careful of how we do it.
Very much. Yeah.
Does that help answer your question?
It does. And are those restrictions sort of self-imposed or clinic-imposed, or are they from sort of the state level down?
At this point, it's pretty much voluntary.
Okay.
There's guidelines that are in place that by our American Academy of Family Practice, for example, and pain management, have some guidelines that we follow. There's no mandated laws that tell us you have to do that. If you want to avoid the DEA knocking on your door, you better be smart about how you do that in terms of quantity of how you prescribe, how you see patients. You're going to be looked at, and I'm sure our clinics have been looked at. We may not even know it because obviously they're looking at numbers through pharmacies that they can see. But I guarantee if they came into my clinic and reviewed my records and saw what we were doing, we would be fine.
Yeah.
Because we did put those measures in place to protect ourselves and take better care of patients. That's the whole point.
Right.
It's all about patient care. Yeah.
So one of the last things I wanted to ask you about is I'm eager to better understand pre-existing conditions, and specifically, so the way I understand the implementation of the Affordable Care Act is one of its main advantages was that it made it impossible for insurance companies to provide people with different rates based on those pre-existing conditions. So I'm eager to better understand that, and also specifically how do doctors go about documenting pre-existing conditions, or what ultimately ends up qualifying as them. Start there.
Well, we don't. As a physician, I don't really look at it that way. When a patient comes to see me, if you came to see me as a patient, say you're a new patient and let's say you have heart failure, you come to me and I'm going to do a initial intake history and physical. I'm going to ask all the questions about your past health history, your medications, put all that together, and that would obviously there we'd have documentation of your pre-existing conditions, whatever they might be, unless you didn't share that with me. If I asked you questions you didn't answer. So that's how that stuff ends up in the record is just by getting an accurate health history. So it's, it's a disincentive for patients with those kind of scenarios to not be honest and share their health history with me if that was in the mix. If they, for example, told, when they were signing up for insurance that they didn't have a particular health problem, they know that. And I've had patients even say that to me, say, well, please don't put this in the record, but, I've had a history of substance abuse or whatever it might be. So that's a challenge. With it, since the ACA has been in place, that's not been an issue at all. Patients don't really talk much about that.
Right. Yeah. And so part of what I'm trying to understand is, I think smoking is a really good example, right? Because that's something that, at least on like the primary care level, is pretty easy to conceal. And if that does get documented, like if the Affordable Care Act gets repealed, which is a very real political possibility, can that information ultimately be used to charge the patient like a higher rate? How does that? Yeah, what are your thoughts on that? Is that accurate?
Well, could that happen? Certainly could. I never saw that happen with. Of course, I'm not at the end of it with determining patient rates, for insurance, so I don't know. I've never been in a scenario where I've heard that to be true. Obviously, perhaps was like life insurance. The health risks are higher with smokers, right? We know that, so one would argue that's probably something that could happen. So yeah, that's certainly possible. And then once it's in their health record, like with life insurance, they give a urine specimen or urine drug screen, and they'll do a nicotine test, of course. And obviously, if you smoke within weeks, it'll show up in your urine.
Right.
So that's how they screen there. In healthcare, we don't do that. We don't screen people like that. I guess that may be something that could happen. To answer that question, if that turns out to, goes back to that scenario, some insurance plans may require you to, be blood tested and urine tested before they determine what they're going to charge you. That could happen. Yeah.
So I'm sure that you're aware of all of the debates now of healthcare. As Sean mentioned, these ideas of repeal and just in general, healthcare is top of mind for a lot of people. So I'm wondering.
Yes,
what, in those conversations, what's being missed? Like, what are we not talking about that we should be?
Well, for me, it's just back to the basics. I think that, healthcare, it really comes down to, is healthcare something that people have a right to have access to? And that's really the bigger picture here. And for me, what I do, where I'm at in the chain of command here, it's just, it's necessary. We need to make sure that there's a way to have access for everyone. And I see the Affordable Care Act was a stepping stone. Obviously, there hasn't been an appetite for health care for everybody, like a Medicare for everyone plan. We know that. So the ACA was a compromise, right? That's really what that's all about. I felt it was a stepping stone. We'd see us move further in that direction. And I think the appetite for that, after all this debate's going on recently, it's actually kind of backfired on the Republicans on this particular issue, because you can see that there's once you have these plans in place, it's very hard to take that away, and it's not perfect. There's a lot of things that need to be happen to that to make it better. But in the end, we got to figure this out. We can't just repeal it and going back isn't going to work. That's not going to solve anything.
Yeah.
Yeah, so I think to wrap things up, something I would be eager pick your brain about is what would be involved in. So let's say you were given like a blank check to, I don't know, not necessarily write policy, but craft policy to a degree. Like the political capital wasn't part of the calculation. If you were just to create a system that you think would work the best as a doctor, what would that include? What would that look like? What would be different?
Well, I think one of the biggest challenges is cost containment. Obviously, when you talk about Medicare for everybody or Medicaid or whatever you want to call it, that's, I think, the big push, the big blowback on that is trying to contain costs. And, when we talk about, repealing it and somehow costs are going to go down, that doesn't really happen at all. I mean, I've seen premiums have gone up for everybody, 10% or more almost every year I've worked.
Right.
So think about that. It's impressive.
Wow.
So to make a case that you let the economic powers at play in competition make that work, that I just don't see that as, from my perspective, that to me is not the answer to this.
So really quick, the point you just made is that premiums increase independent of whether or not the Affordable Care Act is present, right?
Well, I don't know what they've done. We're hearing, when you listen to the news, I don't know exactly what numbers are, so I'm kind of speaking just from what you hear.
Sure.
It sounds like premiums have gone up anyway, even with the ACA. I don't know how it's changed relative to what was projected. I just know prior to the ACA, going back through, this is 28 years doing this, that the premiums for healthcare have, and for my own costs, knowing what they are to buy my own insurance for my family, have gone up at significant pace, well above inflation pace for all this time. So, making a case that free market, contains that just isn't for me. That doesn't make sense. That's not solved that. And the challenge you have is this is again back to healthcare. It's not like we're selling cars or something. We're trying to deal with providing quality healthcare for everybody. So I tend to in recent years have become more in favor of trying to figure out how to do Medicare for everybody. And I'm a family doctor, and I know I speak for probably a large percentage of family doctors, but probably a far smaller percentage of specialty care doctors. I would say that because they like to be able to continue to charge what they want and to select who they see, and that's a challenge.
Right.
Yeah.
Well, Dr. Priest, I mean, so your insight has been so helpful. I feel like voices like yours too often are not included in these kind of conversations. So we just want to thank you so much for the thoughtful conversation.
Talk to you guys. Yeah. Yeah, I talk to patients, you talk to administration here in town, talk to colleagues, but I watch the news, I read the paper, you see what's going on out there, and it's interesting to watch this all unfold, and very few people ever ask people like me, well, what do you think?
Yeah, exactly.
Exactly. You don't see that much.
Yeah.
Awesome. All right, thank you so much for making the time, Dr. Priest. It was great chatting.
All right, you guys have a good night.
All right, be well.
Great. Welcome back. I'm Sean. I'm the host, and I am here with our two producers. You want to introduce yourself?
Yeah. Hi, everyone. I'm Connor Priest. Like Sean said, I'm a producer on the show.
Hi, I'm Sarda Dilipala.
Great. And all of us are students at the Ford School of Public Policy, and we're coming in to do a quick debrief on the Dr. Priest interview. We should disclose that the date of the recording of the interview was October 11th, 2017. And recording this a couple months later on January 31st, 2018. But we still had a lot of really interesting takeaways, and the policy landscape around healthcare has evolved a lot since. So, Connor, why don't you kick things off with a few things that you took away from this?
Yeah, I guess first thing, full disclosure, Dr. Priest has the same last name as me. He's also my dad. So I'm just going to refer to him as my dad. That'll be easier. But I think for me, and from the interview and also what I know about what my dad says when he comes home, when he talks about these things more casually, is kind of the issue with Medicaid and perverse incentives for private care doctors and specialists especially to not take Medicaid.
Right, because your dad is a primary care physician, right?
Right, he's a DO. He does, he's like the primary care.
And one of the things he was discussing is how it's difficult to access specialists where he is, right?
Right. Well, Traverse City, Michigan, is, I wouldn't say the city itself. It's been growing. So it's not completely rural, but a lot of the people who consider Traverse City their home actually live in townships that are more rural that are around the outside. So yeah, it is kind of smaller. Like, we don't have a ton of specialists. Like, we only have a couple, ear, nose, and throat. Like, there's a couple people who do GI. Like, it's not like here in Ann Arbor where you can have your pick of any number of specialists.
Right. And the vast majority of patients that your dad sees are medicated patients too, right?
Yeah, a good, I don't know if it's a vast majority, but I think it's definitely over half. For sure.
And the specialists are more reluctant to see those Medicaid patients, right?
Yeah. Well, actually, in a lot of cases, the package that Medicaid offers these people doesn't even cover some of these specialists. So that's like one issue right there that my dad will often talk about is, why is this? I mean, it is government provided, and I mean, I guess that kind of makes sense that it would be lesser than like a premium private package, but like, it's sort of a second class package in healthcare. From someone like my dad's standpoint, like, he actually really cares about the health outcomes for his patients, and like, he struggles to see these people like receiving a second class package where they can't go see the specialists that they need.
Yeah, and I think as healthcare policy students, like, one of the things we care about the most is access, and just like the way people understand these issues and how they interact with them too. And one of the things you were mentioning, Sarda, about the way people from home and other people like in our social circles interact with this. Not everyone really sees it in terms of these accessibility issues, right? Do you want to say a little more about that?
Yeah, I think it's really easy, like when we're in a policy school, to think of things when you're surrounded by people that are very much on the liberal side of this conversation, to only see it that way. But there is another entire like spectrum of thought, and a lot of people who are my friends that are libertarians and believe that healthcare should mostly be through state-by-state basis. So leave it to the states to decide what they want to do because they know their people more than, let's say, someone in D.C., which is a fair judgment to think someone at home would know. Like,
yeah, people in D.C. are going to have different perspectives than people inside of Michigan, right?
Absolutely. I think, just being here at a university where people like just not even necessarily related to policy, but just having casual conversations with people from all different parts of the country, you can just kind of see how people view things differently, how like they go about things differently. And not even state by state, but like, I'm from Traverse City. I go to see a doctor who is also in practice with my dad at a different location with a different staff, and the way that they do things, the way that they keep records, those things are different than when I come see my specialists and my doctors, even here in Ann Arbor, and we're in the exact same state. So, like, even within state, things are treated differently, and outcomes can be different because of that. So there's definitely some validity to the location-based libertarian argument in a certain sense.
Yeah, and then there's this weird sense of just like believing in the market and letting the market do whatever it wants to do, and in that sense they are incentivizing doctors to maybe more be innovative and finding new treatments or just being better doctors. But I think it was Bernie Sanders who took a bunch of doctors to like Canada or a place that did have universal health care, and they saw that they are doctors, so they took an oath to protect and save lives, and that's what they're going to do regardless if they're in like a private market or if they're in like a universal healthcare system and so on.
Yeah, and it's also, I think there's, going back to your point, Connor, about because I think, and you were saying this too, Sarah, how there's an instinctual, understandable like hostility to Washington regulating healthcare policy in Michigan, right? But what we see happening, and I think you were talking about this with how your dad practices, right, is every hospital has different infrastructure. It has different administrative systems. It has different electronic medical records. It has different equipment. It has different billing codes, right? And just to be able to navigate all of that bureaucracy adds a lot of cost to the system, right? Do you guys have any thoughts about that?
Yeah, I think it's easy to look at things and say, if it was all uniform and it was all streamlined, that would be nice. Like, you could probably cut some costs here, cut some costs there. So I don't know. I think there's validity to that argument. But I'm not sure how big those costs really are, and that's just kind of a byproduct of me not working myself in the industry. But I'm trying to like think, for me personally, coming to see a specialist here in Ann Arbor, like I'm trying to think of an example of how the change might have, caused an administrative cost.
Right.
I think that it probably is higher up the chain than at the actual place where the healthcare is provided. Probably has more to do with like the insurance office and like all the electronic medical records. There are certain regulations on that obviously goes to Washington or to some other bureaucratic office somewhere. But I'm sure you're right. I'm sure there are costs that could be cut by sort of like making it more uniform.
I think you mentioned it too, Sean. It's just there's a lot of like administrative costs associated with like people. It's almost like the efforts are being doubled in like within a state and also in DC. But I think at the end of the day, it's like a couple like more thousands of dollars versus like another person having access to healthcare, and how to equate those things. And I think like people have taken economics and here, like they know you can attach a willingness to pay and like kind of monetize that value, but at the end of the day, is that really the same thing? I'm not quite sure.
Yeah, that's a great point. And I think that it's another. So one issue. I'd be curious to hear. Do you think those arguments about standardization, right? Because we all have close friends who are libertarian and are for much smaller states than we are
Absolutely.
as public policy students, right? Like those arguments about standardization, because administrative costs in the United States for healthcare are, I forgot it, it's either 30 or 40% of total healthcare costs, which if you do the math, I believe is something like $800 billion a year. That's a big number, right? And like I think that if that were to go towards, Medicaid or access, like that would be valuable. Do you think, but I guess, I feel like I'm echo chambering again, right? Do you feel like those arguments resonate with our friends from home, with folks who think differently than us?
Well, when you bring it up that way, this is a conversation I would like to have with some of those people, because these people we're talking about, from my experience, are mostly big fan of, private business. And if you look at the model of a private business, pick any chain store, they're all going to be run uniformly. There might be some tweaks based on location, but like, it's going to be run uniformly. And like, I think there's a reason we see that with all these major corporations.
Yeah.
Like, just from, basic abstract, like, sociology of organization classes that I've taken, that's like a good way that they kind of came up with, right, when private enterprise was kind of becoming a widespread thing, was like this corporate top-down structure. There's kind of like a reason why there is like uniformity in these corporations, so that they can maximize profit and make sure that they're trimming their costs. So yeah, I'd be curious to to bring that up with someone who argues from the other side.
Yeah, I agree with the same thing. I feel like these conversations are harder because we're all like on one side of it and we like refuse to pretend like we're on the other. So I'm curious what the other side would have to say to that.
Right, because it feels like, I don't know, if we do want to think about healthcare as a market good, right? And that's a really big if. Like I choose to see healthcare differently as a right and focus on accessibility. But if we are seeing it as a market good, we value things like standardization, right? Like there is, I don't know, decentralization by definition makes it more difficult to standardize things, right? There's one more thing that I'm really eager to talk about before we close out, because I asked Dr. Priest about this, and it's something that I've been doing a lot more research around, and now I'm actually in a class with Professor Udall Phillips, who is part of our previous interview. But there's a major issue with the supply of doctors inside of the United States. We have a lower doctor per person ratio than other countries, right? And compensation for MDs in the United States is relatively high compared to other countries, for sure. And one of the reasons for that I didn't realize points to a culprit that nobody's really thinking about or talking about.
and it's actually the American Medical Association. So what I found out is that they put a cap on the number of residencies per year.
Really?
Yeah.
Wow.
Yeah, so it's really interesting because obviously residencies are the requirement after you get your MD, right, to become a doctor, right? And one of the limitations, if the number of residencies is capped, then the number of new doctors that we're creating, so to speak, in the United States is going to be capped as well, right?
Right, and also as a result, I would assume that medical schools are going to be like lowering their class sizes as well.
Yeah, definitely.
Because they don't want to admit people who aren't going to be able to become an actual doctor. I'm assuming, because we all know the bureaucracy of higher education is just sort of brag down and talk about how great your graduates are doing. So if your graduates can't get their residency, that would make sense. At least that's the way that it makes sense to me.
I agree with that.
Yeah, absolutely, and it's really interesting because there was a CNN study that came out. This is actually a few years back, but I believe I need to find the exact study. But it was something like there are 30% more MD graduates than there are spots for residencies in each graduating class, right? And we all have friends who are studying for their MCATs, or we're at that point and might be in medical school right now, right?
Right.
And it's not easy, right? Like it's extremely stressful and really difficult and really competitive. And part of that is, yes, to your point, Connor, like the number of students that medical schools accept is relatively small, and therefore the number of new doctors we mint every year is relatively small.
Right, and there's something to be said about limiting your class size, because you want really smart people to be doctors. They don't want to just be letting anyone into medical school. But I do think that there's probably more qualified people than are allowed to become doctors every year, or allowed into medical schools every single year. So
Right.
that's interesting. Another thing that I probably would have put my finger on, but like, I don't know, maybe these articles you were reading talk about it, but I would have guessed that part of this shortage you're referring to is people, like, sort of the incentive. There's a huge pay disparity between just being a primary care physician and being a specialist. Just going back to school for a couple more years can pay, double, triple the amount of what you're making with just an MD or a DO. So, I mean, I always ask my dad, like, do you regret not, like, trying to cash in on that extra specialist? Like, and he was like, no, because when I decided when I was 8 years old that I wanted to be a doctor, it was because I wanted to, like, be the guy who checks your, like, heart with the stethoscope, and, like,
Yeah.
that's what he wanted to do. He wanted to actually take care of people. So he says, like, I mean, he's taking a potential pay cut. There's an opportunity cost to that. But how many people are going into medical school not, it seems to me like a lot of people are going into medical school because they are trying to be a specialist and make a lot of money.
Yeah. Yeah, so just like, I guess going back to that perverse incentives argument, like there's the compensation of specialists is going to be considerably higher, right? And specialists are also a lot more finite in supply. And we were talking in class about how they're seen by hospitals as revenue generators, right? And because they're such a commodity, and the number of residencies to create them and mint their jobs, really, to create those jobs, is so low. Because of that, we end up seeing that they have a lot of bargaining power and leverage when it comes to how these hospitals operate. So anytime a hospital tries to change something, like require them to see a certain number of patients, or do anything in the negotiating process, a lot of that bargaining power is taken away, right? And you were describing that too, with just like the difficulty of accessing specialists in less dense areas, right?
Yeah, it's definitely, yeah, I mean, a lack of access to doctors is going to be an issue.
Yeah, it's a serious problem. Okay, cool. Well, thank you very much for your time. I'm Sean.
I'm Connor.
Sarda.
And we're the Michigan PolicyCast.